Welcome, everybody. I hope everybody on Zoom can hear us. If not, please just let us know in the chat, but we did test, so hopefully you can hear us. So welcome. Thank you so much for being here tonight. I think we still have some people coming in. Obviously, this year marks a really important year for Medicare. We were talking a little bit about this before, and every year there are changes to Medicare. This year, there are a lot more significant changes. We were trying to say how significantly these plans changed. And what we got to was that we couldn't put a number on it. We couldn't say 10% or 30%, but we did see that there were a lot of trade-offs in changes in the plan. So you'll hear a lot about that today. And year over year, there are always changes, but as we said, this year really marked a lot of changes. So just a couple of housekeeping items. We are recording tonight, and so we want to get all of your questions. So at the end, when we get your questions, we'll just need to hand the microphone to you so that the people on Zoom can hear you, and so that we can get that in the recording. And so before I introduce our guests, I first would like to introduce Craig Fraley from the Clark County Credit Union. Clark County and Craig have been partners with the series for about maybe 6 or 7 years, and really without him and what they do at Clark County Credit Union, we wouldn't be able to do what we're doing here today. So real quick word from him, here he is.
Thank you. Good evening, everybody. Just to let you know, we're very proud to sponsor these neighborhood health series. We are the medical filled credit union, so we have the charter for medical. But with that said, anybody can join. So we're primarily the credit union for policemen, firemen, medical, but open to everybody. And I've got some magazines out here, so you can take one of these before you leave if you like. And why would you want to join Clark County Credit Union when you have a bank? That's the main reason why you want to join. We do everything that a bank does, but we're better because we're owned by our membership. We pay some of the highest dividends in the country on our accounts. And just for an example on that, so far this year, we have paid back to our members directly over $35 million. There's not another competitor in town that can say that. And you can join online or over the phone. So magazines out there if you like. Have a wonderful evening, enjoy the presentation, and have a good holiday.
Thank you. Thank you, Craig. Just checking to make sure our guests on Zoom can hear, and it seems like they can. Just a couple of special people that I'd like to acknowledge before we acknowledge our speakers and presenters. There's special people in the room. Wayne Young, he is an independent broker, and he's been helping the Medicare Call Lab for a long time. Thank you. Laura Talbot, who's part of the Roseman family back there in the corner. Dr. David Rawlins, who is on Zoom tonight and happens to be one of my most favorite beloved faculty members, who's no longer at Roseman. He's dialing in all the way from Virginia, so I hope he can hear me. And so with that, I'd like to introduce our panelists. So Dr. Michelle Young, Dr. Michelle Hunt, I'm sorry, excuse me. She is one of those rare people and special people that came to us first as a student and is now faculty and helping out with the Medicare Call Lab. She actually graduated with her PharmD in 2018, and she is the Director of Student Affairs and Associate Professor of Pharmacy Practice. We also have with us tonight Alexandra Van Stone, who is a graduate of our MBS program this year. We also have Kelly Chung with us, PharmD, class of 2027. And then last but not least, Teresa Rawlins. Teresa got her bachelor's degree in biology and has worked at the Roseman Call Center for the past 5 years. She enjoys the rewarding nature of this work and in her spare time likes quilting, canning, and being with or FaceTiming her 12 going on 13 grandchildren. Yes. Whew, that is worth clapping for sure. Yes, and we are so pleased to have her here with us today. And with that, I'll turn it over to Teresa.
Hello, everyone. Thank you so much for being here. So happy to be here. We've been so fortunate enough that the Neighborhood Health Series has allowed us to speak every year for many years. Even when I was a student, we were doing this, and I greatly appreciate being able to come back. I'm going to just hide this little control so we can get a little bit better view of everything. Maybe. All right. So again, thank you so much to our sponsors to allow us to come back here year after year so that we can speak and educate you all, answer questions that you have to maybe help you in your enrollment into Medicare, or maybe for that of someone who you love, a loved one, a friend, etc. So just want to give you a little bit of history of how we came to be. So this call center at Roseman actually started about 10 years ago. And the history of it is because when my partner, Dr. Leiana Oswald, she's a co-faculty member and is the one who wrote the initial grants to get the call center started. She had a student at the time who's now a pharmacist approach her and said, gosh, remember when you graduated and Medicare Part D coverage was brand new and how much you struggled with trying to help our patients with this new program? They have doing these call centers and colleges of pharmacy are partnering and helping out educating pharmacy students, et cetera, to learn about the process to better help their patients. So with that initial conversation, she flew up to California to another university to see how their center or how they were helping their students, their pharmacy students, learn to educate the next generation of healthcare providers. And she was able to bring that back. She wrote for grants to help pay and fund and create the call center, fund us with being able to buy telephones, Surface Pro, so that we can help our patients directly. And thanks to her 10 years of pharmacy students, volunteers from the community, and even pharmacists and technicians have also come back to learn about the process to better help our patients. But really, it's so wonderful to have this partnership and how many people and the impact that we've been able to have. Over these past 10 years, we have been able to save beneficiaries in the state of Nevada, just the state of Nevada, over an estimated over $3 million of savings, whether it's enrolling in premiums, medications, so many other things. So it's an honor to be a part of that. I myself was a student in this, and now to be able to be a faculty member and helping advising the next generation is amazing. And you're gonna learn a little bit more about what these wonderful panelists all do and contribute to this as well. And part of it, a lot of this had to do with some grant writing. And in addition to the kindness of people like Clark County Credit Union sponsoring these talks, for Roseman University for allowing us to operate a call center out of the space on campus, we also have to thank Dignity Health for their continued funding, helping us continue being able to do these trainings, to help hire workers in, to train our volunteers every year. We've also had a wonderful, wonderful partnership with Nevada's Department of Health and Human Services, Aging and Disability Division. They help make sure that our volunteers are certified and credentialed and are up to date on the newest information with all the updates that are happening every year. Our initial grant to buy the initial technology for the rooms was from Noble Cause. And without this continued history and partnerships, that's how we're able to be here today. So thank you so much. And I have the honor to hand this on over to a current student and to hear a little bit from their perspective and how this has come and benefited them.
Hi, everyone. My name is Kelly. I'm a PharmD candidate of class of 2027, and I've been involved with the call center since the summer before I started my P1 year. And it was a great opportunity for me to be give back to my community at the start of my pharmacy career. So we had a training. We hold multiple trainings throughout the year, and it's open for pharmacists, pharmacy technicians to get their continued education, and also like all those pharmacy students and even any community members that are interested in being certified. And for me, during my application for pharmacy school, I wrote, I want to give back to my community. My parents immigrated to the country and they don't speak English as their first language. So I'm actually was able to like help some beneficiaries that were navigating the Medicare system. I assisted Lexi with a call where we helped a Chinese bunny see if she's eligible for for the extra help for one of the drug assistant programs. And although unfortunately she wasn't able to be qualified, but it was a great thing that we were able to communicate and bond through language, and also she was able to receive help. So I think this is like a big, meaningful thing in my pharmacy career. Thank you.
Hello, hello. My name is Lexi, and I'm coming up on my first year working in the call center. Let me advance the slides. So I'm just going to touch briefly on two of the savings programs that are offered here in Nevada. The first one is a federal assistance program. It's called Extra Help. We get people calling in sometimes, asking, oh, can we get some extra help here? We just need to help understand our Medicare. but there's a program called Extra Help. So it gets a little confusing sometimes, but basically Extra Help is an assistance program that helps pays for prescription drug costs, premiums, deductibles. It just gets those lowered for beneficiaries that are eligible. So the eligibility would be based on income and resources. Then our other one is MABID, or Medical Assistance to the Aged, Blind, and Disabled. This one is the state savings program. It's essentially Medicaid. There are a few different levels, so different qualification levels, but the main point of this one is it helps pay for that 185 Part B premium. And the next slide here is just, I wrote down some feel-good stories. So of course, anytime we're able to help out or educate a beneficiary, it's a great time, but just a couple standout stories from last year's open enrollment. We helped a beneficiary who had battled stage 4 cancer for 5 years, and she didn't know about the welfare program. So we sent her to MABID, and she was able to get that 185 premium waived, which is of course amazing because it saves beneficiaries over $2,000 annually. Another story, I did this one actually, assisted a beneficiary who was just released from prison after 17 years. I helped him to understand all about Medicare, and we got him enrolled in a program that suited all of his needs, covered everything for him. Another story, we saved a low-income beneficiary over $1,000 for the rest of the year just by switching her Medicare Advantage plan, and then it helped lower the cost of her Xarelto. So yeah, those are just a couple feel-good stories that I like to share, and we'll have a lot more coming up since it is open enrollment. I will pass it over to the lovely Teresa. Thank you.
It's great to be here tonight. I'm really excited that we're celebrating the 10-year anniversary of the call center at Roseman, and you've heard some incidences of the times when we've been able to help beneficiaries. I was on the phone with quite a few again today because the open enrollment started yesterday, and so every story is an individual situation. Our health is important to us, and our health care is very important to us. And so that's why this position, this job is so rewarding, because every call is helping someone with their life story. So this is a reminder, this slide, that MAP, the Medicare Assistance Program in Nevada, is an umbrella over 3 different programs. So just to orient you to that, SHIP, SMP, and MIPA. Every state has a SHIP office, State Health Insurance Program. So we are SHIP, but we're also SMP. SMP educates about Medicare fraud prevention. We make that a part of every call. And then the MIPA portion is helping the low-income beneficiaries get pointed to the correct subsidies, the ones that Lexi just spoke of. So that's an umbrella, and we're trained in doing all of those things. A brief overview of Medicare, which has been around since 1965 and was never designed to entirely pay all of medical bills. We'll talk about the portions that it does pay. It's for people 65 and older, and also anybody that's on Social Security disability. They also have Medicare in the very same fashion as the elderly individuals in our community. We're now to where it's covering 69 million people. So very important that we have an understanding, because that's a lot of our population. Particularly in Nevada now, we are about at 18% of the population of Nevada are individuals on Medicare, whether from disability or from age. So it's important to understand. This is the official Medicare card, just putting it up here for your recognition. A and B, we'll talk about what they are. And just note on this card, Medicare always begins on the 1st of a month. So you would never see the middle of the month, or people's Medicare always begins on the 1st of a month, of their birthday month, unless they have a birthday on the 1st of the month, and then it happens to start the month prior and they have that coverage a month before their birthday month. We like to really highlight the time to sign up because we don't want it to be missed. There are unfortunate circumstances that happen when that time period is missed. So 7-month period, 3 months before your 65th birthday, the month of your birthday, and 3 months after. That's the time period when it's initial enrollment for an individual to be in Medicare. Okay. Some of you may be very familiar with these basics of Medicare that we're going to go through. And if you are, I'm going to challenge you to get it even more deeply rooted in your mind so that you can share with your neighbors and your family, because we feel passionate about this education, again, because we sometimes see the consequences of when people did not know what they needed to know at the right time. And so whether you've seen this before or it's new or you want to see it again, keep that in mind. Medicare has 3 parts, and then there's 2 ways to receive those 3 parts. I'm going to say that again because that helps eliminate a lot of confusion. Medicare has 3 parts, and there are 2 ways to obtain those 3 parts, okay? So the 3 parts are A, which is hospital, B, which is medical, and D, which is drugs. We'll go over those more. So speaking specifically of Part A, that's your hospital coverage, inpatient hospital. It also covers going to a skilled nursing facility. We call them rehab sometimes, following hospital stays. It also covers hospice care and the home help that you receive following time as an inpatient in the hospital. So that's A. Part B is medical and covers many other things medically. Doctor's office, labs, durable medical equipment. So sometimes people have B and not A, but to have the hospital plus the medical is obviously more comprehensive. Then we have D, D for drugs. And you have to have A and or B in order to have D. And it's expected that you'll get D, required. We'll talk about that more. Okay, let's talk about the eligibility for Medicare. And this has a few new things on this slide as well this evening. You are eligible at 65 if you're a U.S. citizen or a permanent legal resident for the last 5 years. And that asterisk is just there because that was formerly the case, but newly with the legislation that's been passed this past summer, there are changes to Medicare eligibility, sweeping changes. In 2027, that immigration status is going to require these 3 bullet points that are here: a green card, certain Cuban or Haitian immigrants, or people residing under COFA. That includes people in the Marshall Islands, Micronesia. It's a special group that will be able to still be covered. Aside from those, even if you have been here as a legal resident for 5 years, you will not be able to have Medicare coverage come 2027 unless that changes based on legislation. So whether we're talking about refugees or people that have political asylum or domestic violence, refugees that are survivors of domestic violence or humanitarian needs, some of the exceptions where they have previously been able to have health insurance as an immigrant, that is going to be no longer the case in a year's time from now. Part A, indicated on this slide, the hospital part that we spoke of in that picture, is usually free. And I say free meaning premium free, not free to go to the hospital. So Part A, the hospital coverage, when you have worked 10 years in the system, paying into FICA, or you're married to someone who has done that and you've been married for more than 10 years, then you have the ability to have premium-free Part A as opposed to paying what it's worth. These numbers in red are the 2026 numbers, which haven't been officially published, and that's why they're in red. We're still waiting for that to happen, but it's projected for next year for that 563 to be the cost, or 310 if you don't have the 40 quarters. One's the 30 quarters to 39, not quite the 40, but under 30 is the other figure. Okay. I feel positive that you have questions as we're going through these things, and so just make note of those in a paper or the phone note, and we'll absolutely address those as we're going through at the end. But some things may be answered as we go through as well, so hang in there. Okay, so this is a question we speak to beneficiaries about a lot. Should I sign up for Part B? It's my 65th birthday, and I'm still working. And so that's the question. If you have active coverage still from an employer, then it's really your choice. It's important you talk to your employer, because employers have different rules of their own with their own coverage and their enrollment periods and so forth. But you can make a pros and cons list of what you're paying for your employer insurance versus what Medicare would cost, and we can help you provide you with those numbers. And then that's your choice. You can continue to have coverage from your employer and defer Part B. That's very simple to do with Social Security. Or you can say no thanks to your employer coverage and become a Medicare beneficiary upon your 65th birthday. So that is something we can have individual conversations about. And this just notes that active coverage and being an active employee is different than retiree coverage. Some employers also provide their own advantage plans or their own supplemental plans. So that's why it's important to talk to us and talk to your employer about that question. The other part of making that decision of signing up for Part B is the cost. And here again, we have the numbers in red. It's been $185 this year, and it's looking to go up to $206.50. So whether that's better or worse than what your employer is charging you for health insurance, then you're empowered to make that decision. And just a note that the figure that you pay for your premium changes based on your income. $206 is a base premium. If you make more, you pay more. And the making more is set at $109,000 for an individual at this point. If you make more than that, then more is added on to your base premium. And we can talk to you about those specific figures as well. And then there's a deductible, a yearly deductible, for which you would pay for services before your Part B coverage kicks in. That's looking to be $288 come January. So those are things that cost to be aware of as you're making those decisions. Then once you're in and you've paid that deductible, Medicare covers 80% of Part B charges, and you are responsible for the other remaining 20%. Preventative services are covered and free to you. Okay, remember that I said there's 3 parts of Medicare, but there's 2 ways to obtain those 3 parts. So here is an important visual, and take some time looking at this because we reference it through the rest of the program. So original Medicare is on the one side with the different parts in their boxes versus an Advantage plan. And when I'm speaking with beneficiaries, this is the biggest thing that they need to think about and decide what is best for them. So with original Medicare, you've got your Part A and your Part B, which we spoke of. You're not likely paying for the Part A premium-wise, and you're going to pay about $200 for your Part B. And then you need to add drug coverage. That's required to add that. And you can choose if you also want to add a supplemental coverage, also called a Medigap, because the Medigap will cover the 20% that the Part B is not covering. So that's a big gap, and that there's no cap The government puts no cap on what your 20% could become within a year's frame. So even though 20% may not seem like a lot, it's substantial for a hospital stay or any kind of major medical situation. So a Medigap is a very important consideration. So you see that you are adding a few costs together for original Medicare. An Advantage plan on the other side is called Part C to make things even more confusing. And Part C equals A plus B plus D. They're all rolled in together, and you have your coverage, and you have it for the cost of what the Part B premium is. In Nevada, most plans have no additional premium. You pay the $206.50, and then you have coverage for A and B and D, and you're not looking at another 20% to pay. But there are other consequences that we'll talk about on these slides. So be aware that when you've made that choice that was on the one side, the Medicare Advantage plan, those are the HMOs, the PPOs, and the special needs plans that you hear largely being advertised right now. HMO requires more referrals, and you'd have to go to the doctors that are contracted with that company and not anyone else. With an HMO, you do not go out of network. That's not a choice. With the PPO, you can choose in and out of network. It's a little more expensive to have a PPO than an HMO. And then the special needs plans exist for people on Medicare and Medicaid. Those are called dual D-SNPs, or there's chronic special needs plans, C-SNPs, for people with chronic conditions. Okay. When you're making that big decision, these are the factors to consider. 3 things: health, cost, and lifestyle. Health, because depending on how healthy you are and how many specialists you need to see, you may be able to be satisfied on an Advantage plan because you don't have to get 7 specialists into that same network because your health is not requiring that you see that many specialists. So that's part of why health comes into play there. If in an original Medicare, you can go right to any specialist and there's no limit because of these contracts. In the Advantage plans, there are. You saw that the one is more costly. The original Medicare is more costly because of adding the B plus the D plus the cost for a Medigap policy, which is about $200-ish. So another kind of doubling what you're paying for Part B. And then lifestyle is important because if you travel and you're in different parts, half the year in one part of the U.S. and half the year in another part of the U.S., original Medicare, you're able to see any providers, and in Advantage plans are local networks that are based on your zip code. So you need to consider that with making that choice. Here's just a graph that sums some of those things up that we've talked about through the course of that. I'll just let you look at that for a minute. The Advantage plans are private insurances, so they compete against each other to provide your health care. Okay. Just talking in a little more detail about new things on the horizon with Part A. The 2026 deductible for a hospital stay is projected to be $1,716 for days 1 through 60. So this too is why you would want to consider having that Medigap policy, because without the Medigap policy, any hospital admission, when you become an inpatient, you're paying $1,716 just to be there. And then the price increases as you stay there. If you have a Medigap policy, then that is taken into account by the monthly premium you're paying for your supplemental policy, and that they pay that for you because you're paying them to pay for that. Okay? It's important to understand what's not covered by Medicare, and we mean original Medicare. In this slide, dental care is not covered unless it's something from a medical source. Eye examinations where you would go to an optometrist to get your glasses prescriptions would not be covered, and hearing aids. Those are the main things, and these other things also take into consideration. So since they're not covered by Medicare, some of the Advantage plans bring them to the plate because that helps the Advantage plans be competitive and offer services that are not included on original Medicare. So it's another important consideration as you're deciding what's best for you. I like to have this slide up just so you visually can see what cards you're carrying when you are participating in original Medicare. If you're helping a family member or a neighbor and they pull this out and they say, I've got to go to the doctor and this is my insurance, it can be confusing. And so it's helpful just to understand what's required with what. With original Medicare, you're going to have that important red, white, and blue card and an additional card for your Medigap. So one's paying the 80%, one's paying the 20%, and then you are showing the pharmacist an entirely different card because you purchased a separate Part D plan. That's with original Medicare. Whereas on a Medicare Advantage plan, you still are a Medicare, you still hold your Medicare card that Social Security issued you, but you keep it at home in a safe place away from anyone knowing that number and keeping that private. We say treat it like a credit card. And the card that you are carrying and showing is the one that came from whatever Advantage plan you chose to go with. And you're showing that at the pharmacy, the hospital, and the doctor, one card. Just some comments about D being required. Technically, you can choose not to enroll in D, and some people do make that choice. Just go to a pharmacy, say I'm paying retail cost, I don't have a Part D plan, and you just need to know at the point you should ever want it and should ever have a drug where you didn't want to pay the retail cost because you had something come about in your health where you need a medication for that, and you decide, oh, I wish I had D, you will pay a late enrollment penalty for however long you went without it from the time you were 65, and you'll pay it for the rest of your life. So that's why we like to talk to everyone when they're 65. And this is the Medigap chart, the other policy you would purchase should you choose to go with original Medicare. There's all those alphabet choices. Most people go with either G or N. They cover the most things, and that's something that you can talk to. You would have to talk to an agent or a broker. We can help you with Advantage plans at SHIP, and we can help you with D plans. We can advise about the basics of Medigap, but they have to be written by licensed agents. So you would see someone for that. This chart is in the online at medicare.gov and in the Medicare and You book as well. The reason we are even having this presentation tonight is because it's open enrollment time as of yesterday. And that time period exists for people to change their plans. It's centered around D, but D is a part of the regular prescription plans, and it's also part of Advantage plans. So those changes can be made during this period until December 7th, and will start January 1st. To be aware of other times when you can make enrollment periods, we're in the open enrollment now, but come January 1st to March 31st, that's a time if you started a new plan and it's not for you, you have those 3 months to say, wait a minute, this was not what I expected. Let me figure something else out and make a change. That's also the time when if you didn't get into Medicare when you were supposed to, then you have to use that time with Social Security between January and March to get into Medicare and pay the penalty for however long you didn't have it when you were supposed to get it. The last one references the fact that you can try out an Advantage plan for a year and then go back to original Medicare if you didn't care for an Advantage plan. You would not, however, be able to get a Medicare supplemental policy without doing underwriting. But let me just go back to that for a minute. I didn't point out that you can have a Medigap policy and not provide any knowledge of your health troubles, your health history for the first 6 months that you're 65. It's called your guaranteed issue right. And so that's advantageous if you're going to be on Medicare, original Medicare, to obtain that policy during that time period so that they have to give you a policy and not add extra cost to it because they know about your cancer history or whatever your history is, which they can do and will do once you're outside of that initial enrollment period. So the 6 months when you're first 65, and also if you've deferred your Part B and are working until you're 67, 70, and using your employer insurance until that point, then you can also have that same guaranteed issue right to get a Medigap policy during that time period when you're new to Medicare as a new retiree. So it's also important to note that in Nevada, as of 2022, there's a birthday rule. And some people spend a few years, so only a few years, so some aren't yet aware of that. But it's a benefit because 43 states don't have this ability, but in Nevada, we newly do when you can compare with other policies. And if yours has increased in premium higher than you're happy with, there may be a competing plan from another company and you can switch. In other states, you're very much married to that Medigap policy for a long time. Okay, I want you to see what Medicare.gov looks like. This is a really important website. You can do your own enrollments there if you feel you're under your best own advisement, and you can do a lot of plan comparison there. Here in the corner, I show you that new to Plan Finder as of a couple days ago is a provider directory. It used to be that you had to go to Humana's site or United Healthcare site or Alignment site to put in your doctors and see if they were in that network. That is now available on Medicare.gov itself. And I also encourage you to open up your own account, you or your family members, whoever is on Medicare. That is important to be able to put in your medications and do sorting for what is the recommended plan. It's got a really great tool, and you can have your own personalized account. Okay, the Inflation Reduction Act of 2022 did some things that were really helpful to elderly beneficiaries. The insulin prices were capped at $35, and that is holding. So that is still the same in 2026 coming up. And this year, 2025, was the first time as a result of that legislation that $2,000 was the cap on medications. No matter how many medications you prescribed, no matter how much money they cost, once you hit $2,000, then you've paid what you are expected to pay. So that's just bumping up to $2,100 in 2026. And the new drug deductible is $615. Depending on your plan, some of them don't have you use a drug deductible for Tier 1 and Tier 2 drugs. Others do. And all of that information is on Medicare.gov that you can see for yourself. This is just another visual of that. So you have your first stage when you're paying $615 for your medications, and then the second stage hits the initial coverage where you and your plan are sharing the cost of your medication. But when you hit $2,100 this next year, then it's entirely the job of the plan you've gone with to pay for it. And that brings up the topic of the drug price negotiation. That was also a result of the Inflation Reduction Act of a few years ago. And so a few years ago, the 10 drugs were chosen, and now we will see the results of those negotiations. The part of the law was that Medicare would negotiate directly with the manufacturers to reduce the cost of these medications, and they did. And now we will see that these will be lower prices in 2026. So that had legislation to roll forward through 2027, 15 more drugs. The legislation of this past summer has pulled back on that, and there's maybe not the negotiation that was originally passed into law. All that could be in flux depending on what's happening politically. But these are the ones that will be lower costing for 2026 and saving the Medicare Trust Fund about $6 billion because that negotiation did happen. So that was a help. Another thing that was new last year, but I'm just putting it up in case you weren't aware of it last year, is this Medicare prescription payment plan. And they coined it MP3, where you're actually paying your plan through the year instead of paying for your medications at the pharmacy. And the benefit of that was, since there's a $2,000 cap that you're hit, some of the costs of expensive medications are front-loaded at the top of the year. And so rather than paying your $2,000 in January, February, and March, you can have your medication through the year and pay through it for the year. I'll show you one more slide on that. So it doesn't change the cost of the medication at all. It doesn't save you money or cost money. It just spreads it out. It's a little bit of a funky calculation the way it spreads out. You can see that it's not the cost of the medication divided evenly by 12. There's some interesting calculations that they make. And again, on Medicare.gov, you can put in, even if you don't have your own account, you can put medications in a generic test on Medicare.gov. You just put in a zip code of where you live, put in any medications, and you can play with what would cost what before you're even Medicare eligible, if you're interested in seeing how that works. Okay, so for some of the changes that are coming up, many people were very excited to have a couple companies in 2025 have $0 premiums, and many went to the WellCare prescription drug plans because they offered a $0 premium. WellCare has moved that to $270 for 2026, but Humana has come in at a $0 premium in 2026. So we do still have a premium for Part D that costs nothing if that carries the drugs that you need, and it goes up to other plans that have 100, and the highest one I believe is 149. We lost Anthem as a carrier of a prescription drug plan. There's 5 carriers now for 2026 offering 10 drug plans. So remember, you've got a prescription drug plan. If you're on original Medicare, then you've got the prescription drug plan. If you're on an Advantage plan, there are some new choices. Champion Ally is a new one. We have a couple that are nonprofit. Scan and Select Health are on the market as Nevada Advantage plans that are nonprofit. And that's an official number. The $9,250 is the out-of-pocket max. Nobody really goes that high with the Advantage plans. That's Medicare's ruling, and some of the PPOs may go that high. The HMOs are usually $1,000, $1,500, $2,500, meaning once you've paid that out of your pocket for whatever you needed for your health care coverage, your plan then pays at 100%. So a lot of people pay a lot of attention to that out-of-pocket max on Advantage plans. Also, I've had calls already today that they had the letter and either their drug plan or their Advantage plan is being dropped and will not even be available in 2026. Now, if you've been happy with your plan and you do nothing during open enrollment, it will roll right into 2026. That's not a good idea to not look at what they are changing, and your plan will have sent you letters to say what they're changing and what drugs they may or may not cover anymore. So it's really important to take a look at that. But if your plan is being eliminated entirely, then you are automatically put back into original Medicare with no D. That's the default. So if you don't do something of your own accord, then you're in trouble. So you need to pay attention to that. Okay. Sometimes people are especially interested in these coupons, cards to use at the pharmacy, and that's helpful to be aware of. The main thing is just remember that if you're choosing to use that kind of discount card, they are not counting whatever you're paying towards your $2,100 drug part. You've chosen that you're not going to hit it anyway, so you might as well save through a coupon card, and you can do the math, figuring out what's best for you that way. This was also last year newly implemented to remind you that halfway through the year that maybe you haven't used the benefits that are yours for the taking, so you ought to go ahead and use them. And also a reminder that you don't have to get that book full of how many pages it is. In the fall, you can opt out electronically. Same thing for the Medicare summary notices that are mailed out. There are a lot that use paper, and so if you want electronic delivery, that's a choice you can make, you or your family members, on Medicare.gov. I mentioned we always give a warning message to everyone we speak to, and so we give that to you as well. To be safe with your Medicare number, these are the do's and the don'ts. Do treat it like a credit card, and keep track of your own appointments at the doctor so that when you see the bill comes and you recognize, yes, that's when I saw Dr. So-and-so, and you notice if something's unfamiliar, because the fraud is a real, unfortunate reality, and that robs the Medicare Trust Fund of the funds that we need to pay for the services we really need. So that's an important thing for you to pay attention to. These are the MAP numbers and our Roseman call center number. We also have takeaways here that you're welcome to help yourself to, and to remember our number. So that is the end of the presentation, but now is when we are able to entertain any of your questions that you may have from all the complexities we spoke about.
I talk pretty loud. My question is, if you have an Advantage plan, do you need a gap?
No.
Or that's only for original?
His question was, if you have an Advantage plan, do you need a Medigap? It's either or. You make that choice. Either an Advantage plan, it's illegal to have both. So that is absolutely an either or. Thank you.
Thank you for the presentation. I have one small question about the Advantage plan. So if you mentioned if you travel, there's no coverage. Does that apply even in an emergency? They go on a weekend and they...
That's a great question. No, you will always be taken care of in an emergency situation. The goal is to have you taken care of and then get you back to your home network where you would continue to have service. So yeah, we don't ever want to scare people by saying you can't go anywhere because you have an Advantage plan. In an emergency, that would be justifiable to the Advantage plan. So, sure.
Pass it down. Oh, there you go.
I have a question. When you are using those discount plans like Good RX, you're saving Medicare all that money because they don't pay any of it. Why aren't they tracking it?
So when you are choosing to make that choice, you're saving yourself money and
also Medicare because
because the Part D plan is not paying towards it. Do you have an answer for that, Wayne?
You know, I really don't understand that because you're saving Medicare when you're doing that. And why don't they track it? I mean, they track everything else. They track to make sure you don't, like double dip. You have to wait 30 days to get another sinus medication, all that stuff. So they have the ability to track it.
So I think the big part of that is if you aren't using the deductible, say your health changes and now you do need medications that maybe the good or the discount cards don't cover, or maybe they don't cover enough of. If you have to go back to insurance, you haven't met your deductible. So you're it's a little bit of a gamble in a sense there. So you can use those discount cards. It's just if you ever needed to go back to your insurance coverage, then it's not going towards that deductible. And there's not to say that the medications that are covered by those discount cards are always going to be covered enough. Sometimes you get a discount, They can change how much they can cover. They can change whether or not they cover certain medications. And there are some medications that, while there may be some discounts on it, maybe the medication is, I'm just going to pick a round number, $1,000. Maybe the best discount you can ever get on that is maybe only $100 off. So is that enough? Is your insurance company maybe can do a little bit better on their negotiation? So it's always an option, but it's also a little bit of a gamble too sometimes.
Still doesn't make sense to me.
Hi, everyone. So a possible answer to that as well is because there are a lot of variables involved when it comes to the drugs. It's not just the insurance company. It's not just Medicare. It's the pharmaceutical companies as well. So if you're paying from a discount coupon card, the manufacturers of that drug are losing money. You're saving money, you're saving Medicare money, but the drug company's not, because they're giving a certain population the ability to buy this certain drug. That's why when like a lot of manufacturer programs, they don't cooperate with a discount card if they're federally funded. If it's like they're getting their medications through Medicare or Medicaid, it's because they have a separate contract. The pharmacy involved also is another variable. So when you're shopping around for these drug plans, depending on which pharmacy you're using will also dictate the difference in price of the medication as well. So the what you just said was a great question. That's why it kind of threw me off a little bit. But yes, but there's more than just the two entities involved. It's more than just the it's more than just the insurance and Medicare. So you're not just saving them. You're also forgetting the pharmacy involved. You're also forgetting the manufacturer involved.
I appreciate Wayne mentioning about the pharmacies, because I admitted that today. That's another thing Medicare.gov can help you with, is which pharmacies are preferred by your plan and which are entirely out of network and would cost more. So thank you, Wayne.
When we call the Roseman call center, is it just we're asking questions, or they are making an appointment for us to, you know, for me, I would be brand new trying to sign up. And then the thing is I heard that they may have look at your taxes from a year or two before,
Okay,
but then,
sure.
and then what if you are now divorced or something? You know, what if there's been
Right.
a change in your income or your situation?
Absolutely. So when you call us, if we answer the phone, we have time to talk with you right then. If you leave a message, then we will call you back, and we listen to your story. We listen to all of those circumstances that you just related, because that makes that what advice we give you is pending what you told us about your own situation. So in relation to the 2-year look back, that's absolutely true for the premium cost that you will pay when you enroll in Medicare, and whether you pay the $206.50, they will have looked at your taxes 2 years before. Thank you for bringing that up. They do a 2-year look back. So right now, people that are new to Medicare this November and December, they're looking at 2023 taxes, the modified adjusted gross income on your taxes of what you paid then. And that 2-year look back always happens. It's not always representative of what you're making 10 years or 2 years later. So you can let Social Security know and file an appeal and fight that. But yes, that 2-year look back happens, and whatever circumstances are your individual story, we will take that into consideration.
So they look back, and let's say you were married 2 years ago and you're not married now. Now, would they look at just what you made, the individual made 2 years ago, or they're looking at you as a couple?
That's a great question. And Wayne's gonna take that question. And I just also want to mention that Wayne has a vast background in Social Security. So he has a relationship with Social Security, and that's been a real asset in our call center.
So that particular scenario where you were married at one point, and whether it's a divorce or a deceased spouse and your income has changed, that's a life-changing event that you would be able to use that as an appeal to not, and this whole thing that we're talking about, the 2-year look back, is what's called IRMA.
Income reduction monthly adjustment amount.
Thank you. Couldn't remember what it stands for. Just know the name Irma. We call it a lady Irma. So she's the one responsible for looking back 2 years on your taxes to see if you are triggering a higher income. The reason why it goes back 2 years is because not everybody files their taxes on time, so they can't use the year previous, so that's why they always go back 2 years. But again, that 2-year look back triggers your current year for whether or not you're going to be paying a higher premium. So in a case where now the situation has changed, whether you're retired, whether a divorce, a deceased spouse, and that income no longer is that way, that is the time to use that one-time appeal to be able to offset IRMA or completely get rid of IRMA moving forward. So something that when I was a SHIP counselor, and how SHIP counselors are taught to counsel, is strictly about Medicare. One of the things that you might want to talk to your tax advisors about, because we're not allowed to do that, is asking about IRMA, because it's really interesting how a lot of even tax advisors are not, they're looking at your profile and looking at your retirement funds, but they always seem to either not know or figure out the IRMA may trigger something. So when you're 63, that's another magic number, because we always talk about 60, 62, 65, 67, and 70. Those seem to be magic numbers when we're talking about Social Security stuff. What we forget is about when you're 63, it could trigger IRMA, because that's when you turn 65 or become eligible for Medicare. So just something, I really don't want to go more into that part, because not a tax professional, can't give you tax advice, but definitely talk to, if you've got a financial advisor, a tax person, maybe not the tax person, a financial advisor, and talk to them about your prior 2 years triggering IRMA. I've just a really quick scenario. There's been people where they're retired limited income and they pull money out of their IRA, not their Roth, because that tax has already been paid, but taking a lump sum of money out of their IRA. Because they did that, they triggered IRMA. So they think they're saving all this money by, pulling out of their own account to fix up their house, to take a trip or whatever, not realizing now they're paying a penalty every month for each person of the couple on Medicare, because of that amount that they took out of their retirement and triggering taxes.
And Wayne's comment highlights too, Medicare is entirely individual. So you are paying that premium, both entities in a couple situation are both paying that $206.50, and the separate Medigap policy and the D policy. Okay, thank you.
I just have a, let you know about an experience that we're having.
Okay.
With the insurance, sometimes there are those that drop you off coverage at the middle of the year, or sometimes they decide that that group of physicians are no longer
Yes.
covered. Now, why do you put a person in that situation at the middle of the year and don't wait until they have a chance to change?
It is one of the most difficult aspects of our job, is these provider contracts, because they are not tied to the calendar year, they're not tied to the fiscal year, and so they can end and begin at any time, and we are continually, the most important thing for the beneficiaries we help is that they can see the doctors they want to remain loyal to. And so we spend a great deal of time researching what the status of the contract is, but then you're right, it can change. You can get a letter and it can change, and it's unfortunate.
At the beginning of the year, we tried to, ask what insurances do they, carry, of course. And, during that's especially in oncology,
Sure.
cancer.
Sure.
And that is a very serious thing.
Yes.
And you are in the middle of treatment. There is a contract of treatment from the doctor to the patient.
Right.
And we have to, write a appeal in order to continue until the end of the year. I think that's a very stressful thing in our lives. We are, already 80s and above. So
I'm so sorry that's happened to you, and it sounds very familiar to you. I've been on the phone with the Comprehensive Cancer Institute's billing department many, many times, trying to understand what is best for these the oncologist, the patients absolutely want to keep the oncologist.
Right.
And yeah,
Another situation too is that there are some medications that you found that it fits or it is the best one for you, because some other, medications you have been tried that is covered, doesn't has side effect or something that doesn't agree with you.
sure.
So you stay on that medication, and then the pharmacy department of the insurance had, recommended to appeal to lower down the tier of that medication. And of course, who's going to lower down the tier if they're making that much money?
Right, right. There are things that are authorized to happen, and then there's the reality of will it happen or not.
I'm just voicing out, these
appreciate that.
experiences because I hope they would do a little bit, better and help, because every time you look around, yeah, can I help you? Okay. And I said, yes, if you can.
This is what I would really like for your help
Yeah.
for me.
And
Yes.
the third question, I'm sorry to have so many issues here. This max of 9,250 for the HMO, it's only on the Part D, or
That is a Medicare rule of that's the most an Advantage plan could charge you for a maximum out of pocket. I don't know of any plan that's actually going with that in Nevada because they wouldn't have customers. Yeah, it's much lower for all of the competing Advantage plans. So that's just a rule set by, it's, right, it's an Advantage plan.
It's not that, the $9,200, $9,250 is not Part B, Part A and B that it applies to. $2,100 is what affects Part B. So the maximum out of pocket is called MOOP, M-O-O-P, maximum out of pocket. That is
Let's see where I
referring Part A and Part B. So, sorry, I have to move before Zoom. So the $9,250 is the federal number that Medicare mandates across all states. That's the most you states or you carriers in each state can charge as a maximum out of pocket as an HMO for Part A and Part B. As Teresa was saying, in Nevada, that doesn't really happen, but that is the maximum number that Medicare will allow. Nobody in Nevada even comes close to that, but it's for A and B only.
Separate.
D, the maximum amount for D is 2,100 straight across the board for everybody in 2026.
And that, the 2,100 is the maximum amount if your drug is on the formulary. If your drug is not on that plan's formulary, all bets are off. Then you are paying outside of your insurance plan, and the 2,100 does not apply. Hang on for the mic.
just the last question. I know that there are insurances that are non-profit,
Right.
and most of them are for-profit. Is there any review of those insurances with the nonprofit, how they're,
How they- Right, I mentioned that SCAN and Select Health are the two nonprofit choices that we have right now in Nevada. And I'm sure Wayne or another agent would be happy to talk with you about that business structure and so forth of how they operate.
I just had a question when you mentioned the birthday rule.
Sure.
Are you then subject to underwriting at that time?
If you already great question. If you already have a Medigap policy, which you would because you would be utilizing the birthday rule, then there is no underwriting at that point either.
There is not.
There is no underwriting.
Okay.
Yeah.
And do you
No.
know if Nevada has more than just like the attained age type policies for Medigap, if they have
Great question.
community-based
Yeah,
and
that
others?
is your education that you understand that there are three types: attained age, community rated, and issue aged. And we have all three. There are not very many issue aged and community rated, But because of the birthday rule, it's a little less relevant anymore because every year you can take a new look. She's referencing the attained age used to be you bought in, well, and in other states it is, you buy in when you're 65 and then that at a great price, but then the attained age means it increases in premium price as you age. And so what was a good deal when you were 65, I speak with 80-year-olds that are paying $400 and $450 monthly for their Medigap. But now with the birthday rule, every year during that 60-day period around your birthday, you're allowed to cost compare. And so you can get an attained age because you're going to look at it again the next year if you're working with a broker that's helping you do that.
Okay, so that is a great benefit then. I just had one last thing. So I had a friend who was 65 and then went on Medicare, and then she came back to Nevada and went back to work at like 67. And it was unclear if she would have to go under underwriting since she would be giving up Medigap if she took the Clark County insurance. So do you happen to know that if you like go back to
When you
work?
move to a new state, you usually have a new Medigap time, a new opportunity to purchase a Medigap policy.
Okay, because I mean, they offered at Clark County for her to go on their medical insurance, but she was afraid to go off Medigap because she thought she'd have to go underwriting.
So some Medigap policies are national and others have restrictions, but that would be an individual question.
Okay, all right, thank you. I was just curious because a lot of people, you know, with 67 being the full retirement age for Social Security and 65 being for Medicare, it's very confusing to a lot of people that I work
Glad
with.
She brought that up. That's another thing we clarify. 65 is the age for Medicare enrollment, no matter when you're going to retire. And some people think it has to align, and it does not have to align. They're separate conversations with Social Security. So, Wayne, do you have? Okay, Wayne will cover that answer on that. Thanks.
So going back to answer the question on if someone was on a Medigap policy, returns back to work, drops the Medigap policy, then stops work and wants to get back on the Medigap policy, does that give them a guarantee issue right to not have to go through medical underwriting? The answer is they do not get a guarantee issue right because they only get a guarantee issue right when they either A, turn 65 for the first time, which is actually called open enrollment, then you get a one-time guarantee issue right when you first enroll into Part B. Losing your cover or dropping because you have credible coverage is a Part B issue, not a Medigap issue. For Medigap, because the person is not new to Medicare Part B, that guarantee issue right is gone. So in her case, yes, that would have been a very scary thing to go back to Clark County, take their medical insurance, and then try to come back and get try to get the Medigap policy again. They would have to go through medical underwriting. I'm sorry? Yes, a lot of people will go back to work. So at that time, it's probably a good idea in most cases, not all it's individual, but in most cases, it's probably a good idea not to take the employer coverage and just stay on Medicare and stay what you got.
Teresa, do either plans cover long-term care? You said in original Medicare, no. Same with Advantage?
Great question. Yeah, that's not something Medicare touches.
Okay.
Yeah, that's an important point that you have to take that into consideration with planning finances.
Okay. And second question, if someone was forced to retire early before age 65, and I know you have to keep these concepts separate, and loses their coverage from their employer, their health coverage, and they're not yet 65, do they just have two options? So one would be going on the open market and negotiating a COBRA policy or some kind of policy. And in that case, the second option, they would not be eligible for Medicaid or anything like that.
Medicaid eligibility is based on income and resources. So we do that all the time. As Lexi referenced, there's a figure, it's very black and white. You know, if you're under this, you're eligible for these aspects of Medicaid. And so if someone's income eligible, they can absolutely apply for and receive Medicaid. And yes, the marketplace or open market would be another chance for them until they're Medicare eligible at 65, unless they have a disability, which they could apply for Social Security disability and receive Medicare as a benefit of having been awarded Social Security disability.
Okay. And the open market rates, and I know it varies significantly based on your coverage, but is there any sort of like range that families or individuals would pay in the open market without any subsidies from their employer?
That's a great question, Vanessa. We don't counsel about the marketplace. There's other, yeah, you've got to call Nevada Health Link. That's Nevada's open market. And so I don't know, other than knowing it's income dependent.
Yes, and very expensive.
Right.
Okay.
right.
Can we see if anyone on Zoom has any questions? If anybody on Zoom has any questions, please feel free to unmute and ask your question. Nick, I think you had a question. Can Irma be looked at on a yearly basis once you hit 65, since the financial situation can change?
It is automatically looked at annually. They just go back 2 years to look at the current year. But if you're triggered by Irma 1 year, next year they look at the 2 years prior to see whether you're triggered again for Irma.
And you can only appeal once with Irma?
Yes, that's correct. Only once.
So you need to wait until you've gotten your income down to the lowest tier you think it's ever going to be at.
Can you repeat that, sir?
So you should wait until your income is at the lowest tier you think it's going to be at.
If you can predict it.
Yeah, so I mean, for example, I'm going to have to take 2 RMDs next year. So the following year, my income will go down because I will not have double RMDs. So I should actually wait until not next year, but the year after, and then appeal.
Hold on.
Except that the Irma consideration is based upon the fact that your situation has changed and won't return.
Oh, so if I do it next year and I have 2 RMDs, then the following year I can appeal again because my situation is I only have 1 RMD.
You can, but it probably won't, they probably won't approve it.
Got it. Okay, thank you very much.
You're welcome.
I appreciate that question actually though, because with the Medigap and the birthday rule, I didn't clarify that you can go to the same policy or less. You can't go up in your coverage. So that whole thing of not being able to predict, that's what reminded me. You have to, guess the future and think up to, by the maximum coverage, because you can always go down, but you can't go up. So with the underwriting. Right. Yeah.
Steve, did you have a question, Steve? You had unmuted for a second.
I asked my question. It was the one about when you can appeal.
Okay.
Thank you.
Sure. Any other questions on Zoom? We have another question here in the audience.
Does the website tell who the 5 carriers are and what the 10 drug plans are?
Medicare.gov, yes.
Okay,
Yeah.
where would you find that? Because I'm looking right now, I can't find it.
So it's just medicare.gov.
Oh, no, I'm in Medicare.gov
okay.
and I have an
Okay.
password and all that. I just can't find.
Okay, so
who
find
those
compare
carriers are.
plans or find a plan. You go through the process as if you're trying to compare a plan and find one for you.
Okay.
And they'll have you enter your zip code. And then once you've done that, it'll ask you if you want to add drugs, yes or no. And then whether you do or not, it'll ask about pharmacies, it'll ask about providers, and then it'll list all of the options for you. And you can sort by carriers. Okay, of course.
Any other questions? Oh, here's another question up here in the corner. Hold on.
I was just curious if when people are turning 65, like say that my birthday's in October, do you have to pay the full deductible for October, November, and December, or is it prorated on these A, B, and D?
It's not prorated, yeah.
Okay, so you just kind of screwed.
year, right, right. On the flip
Okay.
side, like if you're joining an Advantage plan that has $2,000 of dental benefits,
Uh-huh.
you've got them for November and December, and then it resets for the whole.
Gotcha.
whole
Okay,
next
that makes
year.
sense. Yeah. I just wondered. I just been reading a lot about Advantage plans and how they, have pre-certification requirements and, 10 to 15% of the time things are denied. And so, knowing you can only get on Medigap once without underwriting, I think, it's something to think about. Thank you.
Absolutely, right. It's a big decision and very personal. So that's why we listen to your story, and we're unbiased, but we help you decide what's best for you.
Any other questions? Well, thank you so much to our panel. Thank you, Teresa. Thank you, Wayne. Thank you,
pleasure.
everyone that's been
Yes,
here. We really
feel free to
appreciate it.
Call us and tell your friends. Thank you. Thank you. Thank you so kind. I was just Dave.